is Sarah Boudreau. I work on the policy team in the Public Health Division here.
And I'm Rebecca Pavlik. I work in health promotion and chronic disease prevention here in the health division, and we're going to be talking about modernizing the public health system today. So Sarah's going to go first.
I am going to go first. I will give a little caveat. If you work in the public health division and you have seen us do modernization overviews a few times, that's basically what we're doing here today. So if you start watching and you realize you've seen it all, you're not going to offend us if you leave. We will be providing just a little bit of information about the modernization assessment that's being completed, but most of that information, or more of that information, will be shared with Public Health Division staff at our April 4th Friday modernization session. So just with that little caveat, we can go ahead and get started. Thank you all for participating in Public Health Week and for attending this session on public health modernization. I thought it might be helpful to start with just a very short discussion about the role that public health plays in all of our lives. So this slide has some images about how public health touches our lives, from immunizations to safe drinking water, healthy families, healthy aging, protection from communicable disease. These are just some of the ways that public health protects and promotes our health every day. A lot of times when we're thinking about what public health does, we sort of think about three buckets. So we have a big role with assessing and monitoring the health of our population, and for diagnosing and investigating when emerging threats occur. We have an assurance role, so we enforce public health laws and regulations. We also assure that people have access to preventive health services. And then finally, we do a lot of policy development around health protection and promotion. So just to go backwards in time and share some of the history of public health modernization. So public health modernization really started in the 2013 legislative session with the passage of House Bill 2348. And this bill called for the creation of a task force to study and then make recommendations for building a public health system in Oregon for the future. So the task force was made up of elected officials, a county commissioner, local public health administrators, leaders from community organizations, and other public health stakeholders. This group met for about 14 months. They took a deep dive into our current public health system, explored what our system needs to be, and then submitted this report, Modernizing Oregon's Public Health System, back to the legislature in September of 2014. So just high level, what their recommendations were for moving our system toward the future. The first thing is that they recognized a need to clearly define what the public health system needs to provide. And what they did is they looked to a set of recommendations that was put forward by the Institute of Medicine back in 2012, which refers to foundational public health services. So the task force recommended that we use those foundational public health services and follow that model in Oregon, although we tend to call it modernization or foundational capabilities and foundational programs. But really we're referring to that work that came out of Institute of Medicine. The task force also recognized that if we're going to change our system and move toward the foundational capabilities and programs, that there needs to be significant and sustained funding for that work. So it's not work that can happen with no resources. The task force also recognized that we cannot use a one-size-fits-all model in Oregon. Our communities are very diverse, our counties are very diverse, and counties need to come up with the correct solution for how to meet the foundational capabilities and programs in their own area. So some counties might be able to do that entire body of work on their own, and that's great. Other counties might come together to share some services, so share an epidemiologist or share work on communicable diseases, and that's a great model that's going to work in a lot of areas of the state. Other areas of the state also might look toward regionalization or forming health districts, and that's another good option. But the task force just recognized that there needed to be local flexibility to meet each community's needs. And then finally, the task force recommended that there be a strong governance structure in place to guide us through public health modernization, and they recommended that the system needs to be very outcomes driven. So they recommended that our Public Health Advisory Board fulfill that role here in Oregon. A lot of information, but that's the bulk of what came out of the task force. So fast forward to the 2015 legislative session and the introduction and then passage of House Bill 3100. So House Bill 3100 basically just adopted those recommendations that were put forward by the task force. So House Bill 3100 adopted the foundational capabilities and programs. So that's the standard for state and local public health in Oregon. It changed the composition and role of our Public Health Advisory Board. So it defined the members that need to sit on that board and also gave that board a very concrete body of work for seeing modernization forward. It required the public health system, so again, state and local public health, to complete a modernization assessment to assess what we're currently providing and the gap between what we're currently providing and then being fully meeting the foundational capabilities and programs. And it requires local public health departments to submit a modernization plan by 2023 for how they're going to implement modernization in their communities. So a lot of people see that 2023 and think that is a very long time frame, but this is a huge body of work. We recognize that some counties will be ready to move more quickly on this. Other counties, it's going to take more time. You know, this isn't something that just sits within public health, but it's really about meeting a community need. So those are some of the reasons for that long time frame. So when we're talking about public health modernization, we're largely talking about changing our system so it meets our needs today and it also meets our needs 20 years from now. Our existing public health system has been hugely successful in reducing death and disease, but it's still working on the model of what was needed 50 years ago, and it's not meeting our needs as well today. We're dealing with new emerging diseases, different impacts from chronic diseases, health impacts from climate change. So these things are not what our public health system was built to address, and changes need to be made. So public health modernization is built on these foundational capabilities, which you can kind of see are in the center of this diagram up here. And the foundational capabilities are the knowledge, skills, and abilities that should be present in every state and local public health department in Oregon. And I'll talk about what those are a little bit more. If we're able to meet those foundational capabilities, then we're going to be able to run strong foundational programs. And if we're able to run strong foundational programs, then we're working toward a healthy Oregon where everyone lives in a community that supports their health. So I mentioned that I'll talk just briefly about what these foundational capabilities and programs are. Part of the work that we have done since House Bill 3100 passed is really defining all of these foundational capabilities and programs. And we can talk about more of that process in just a moment, but each of the foundational capabilities and programs has a vision statement with it at this point that was developed jointly by state and local public health. And that's what you're seeing up on the screen. So leadership and organizational competencies. The vision is to provide team-based leadership within public health departments that define strategic direction necessary to achieve public health goals, including health equity, and lead stakeholders to achieve those goals. So what we're talking about is having strong leadership in our departments, strong workforce, information technology that meets our needs. We have the ability to manage our budgets and plan our budgets, and all of that work is essential and falls under this capability. Health equity and cultural responsiveness. Our vision is to ensure equal opportunity to achieve the highest attainable level of health for all populations through implementation of policies, programs, and strategies that respond to the factors within culture that impact health and seek to correct historic injustices borne by certain populations. So, health equity and cultural responsiveness, it underlies all of our work. It touches every other foundational capability and program out there. It's about engaging communities in the interventions to achieve health equity, and also really making sure that we have a workforce that represents the populations that we serve. Community partnership development. Relationships with diverse partners allow the governmental public health system to define and achieve collaborative health goals. So our community partnerships work, again, is just essential, and it touches all other areas of public health modernization. It's about cultivating robust partnerships with the goal of improving health. Assessment and epidemiology. The vision: apply the principles and skilled practice of epidemiology, laboratory investigation, and program evaluation to support planning, policy, and decision-making across the foundational program areas in Oregon's governmental public health system. So the focus here is on surveillance of population health and using that data to drive our decision-making. Assessment and epidemiology also includes the work of our state public health lab. Policy and planning. The public health system will implement policies, systems, and environmental changes that meet the community's changing needs and align with state and federal policies that aim to eliminate health disparities, reduce leading causes of death and disability, and improve health outcomes for all people in Oregon. So policy and planning supports the implementation of policy interventions aimed at improving health, and this also includes a lot of our regulatory functions. Communications. The vision is that the governmental public health is a trusted source of clear, consistent, and timely health information. Governmental public health consistently uses health communication strategies, interventions, and tools to eliminate health disparities and achieve equity. So this foundational capability is about building our capacity to communicate about health threats, health policy, and behaviors that impact our health. And our final foundational capability is emergency preparedness and response. So the vision is a healthy community is a resilient community which is prepared and able to respond to and recover from public health threats and emergencies. So emergency preparedness is about planning for events, it's about exercising, and it's also, of course, about responding when emergencies do occur. So those 7, just a lot of words, but again, when you think about them in total, those are the knowledge, skills, and abilities that need to be present in local public health, and largely aren't across the entire state. So there are also 4 foundational programs in public health modernization, the first of which is Communicable disease control, and the vision here is to ensure everyone in Oregon is protected from communicable disease threats. So this is largely about investigation, control, and prevention of diseases like STDs, foodborne illnesses, healthcare acquired infections, and many more. Prevention and health promotion. Our vision is a public health system that prevents and reduces harms from chronic diseases and injuries through policy change, enhanced community systems and practices, and improved health equity that support the health and development of Oregonians across the lifespan. So the bucket of work here is about changing our environments to support optimal health for everyone in Oregon. Environmental health. So environmental health works to prevent disease and injury, eliminate disparate impact of environmental health risks and threats on the population subgroups, and create health supportive environments in which everyone in Oregon can thrive. So environmental health is about assessing and mitigating health risks. We do a lot of work like restaurant inspections, inspections of healthcare facilities, and also a lot of work on things like monitoring the impact on health of things in our environment like climate change. Access to clinical preventive services. The vision here is to assure Oregonians receive the recommended cost-effective clinical preventive services. So this is an interesting one because it's about assuring access, but it's not about providing those services to people. So largely, it's about working within communities to identify where access gaps exist and then working as a community to fill those gaps. I feel like I had one more, but I guess not. So why is now the time to modernize Oregon's public health system? Our public health system in Oregon over time has evolved so that we're often considered a safety net provider within communities. We're actually providing a lot of individual level services to community members. But largely as a result of health system transformation and having so much of our population insured now and hopefully having access through the traditional healthcare system, there's less need for public health to be filling that safety net role. So, it is the right time for us to move away in many areas of the state from providing direct services or providing the full spectrum of direct services, but instead shift our work back to the population level work, which is really, the foundation of public health. So focusing on policies and programs that can help everyone in Oregon is going to yield cost savings to the healthcare system. And I think this is an important point to make because this is a real opportunity for public health to work in alignment with our healthcare system. Rather than trying to duplicate services, we can find out how the systems support each other and have the biggest impact on improving health. Let's see. One of the last bullets there. So one thing we know is that local investments in public health varies widely across the state. Some counties don't put in $0 to support public health, and other counties put in very large contributions to public health. But what that's created is a system where you have different levels of services provided by your public health system depending on where you live. And one of the purposes of modernization is to make sure that there's the same base level of services provided to everyone in Oregon regardless of where they live. And then finally, our current system is largely funded on federal grants, and federal grants dictate the work that we do. So it's great that we have them, but sometimes we have needs that go unmet because we don't have funding to do that work. I think one of the examples that's very much on the radar right now is hepatitis C. So we have very high rates of hepatitis C infection in this state and no federal dollars to support any work in that area. So there's very little prevention work happening around hepatitis C in the state because there's not funding that can support that. I'd love to just pause and ask if there are any questions at this point. A lot of information. Jim?
Nice to hear more about the plan. I always learn something when I see it. And actually, most folks probably don't realize that Oregon has been ranked 46th in the nation for per capita funding to public health from the state, from a state, our state. We rank below states like Alabama and other states that have a lot of high need. I missed the beginning of the program. So is this a larger plan that includes the local health departments, et cetera? Can you talk a little bit about how this was written? Probably did, and then what would be the efforts to try to address the funding gaps in Oregon? I know I speak with legislators now, and they're not really aware. Number one, they're not aware of the public health system unless something goes wrong, and number two, they're not aware that the state's not really putting any money into it. They take Affordable Care Act, CCOs are addressing the safety net population, and all this great work, or what I hear is, oh, we funded this and we funded that.
Right.
And it's all piecemeal.
Right.
And there's no plan to kind of address the system needs.
Exactly, and no one's ever gonna, fund us to do policy work on its own necessarily, but it's instrumental to the work that we do. So yes, when we talk about modernization, we are 100% always talking about the public health system in Oregon, so state and local public health. All of the work that's happened to date has happened just jointly with state and local public health. We'll talk a little bit more about the modernization assessment that's being completed now, but I think that will be one of the really powerful tools to demonstrate current spending for public health and specifically to support foundational work. And that will be provided back to the legislature. We'll touch on that a little bit more. Okay, where we've been. So House Bill 3100, we covered that. I also mentioned that part of the work since the bill passed in July has been to get really down to the ground level with what these foundational capabilities and programs mean. That work happened over the course of about 3 months, jointly with state and local public health. There's a public health modernization manual on our website that goes into the core system functions, the core roles for state and local public health, the core deliverables for state and local public health, and that's available on our website. So check it out if you haven't seen it. New FAB members were appointed by the governor's office in December of 2015. That group is now meeting monthly to fulfill their role around public health modernization, and we'll talk a little bit more about that as well. And hot off the presses, state and local modernization assessment completed in April 2016. Technically, it won't be completed until Friday, but we're so close. I wanted to say it was completed. And actually, I'm going to stop there and pass it over to Rebecca, who will talk a little bit more about the assessment.
Sure. Thanks, Sarah. So I just wanted to point out the graphic that's on the table for you all to take if you want to hang it in your cubes or in your offices. So one of the huge results of this process so far has been those vision statements and the definitions that Sarah talked about. I think working collaboratively with local public health to define for Oregon what the public health system should look like for foundational programs and capabilities has been a huge result and a huge lift in and of itself. And this is a Wordle, I think that's the word for it, where we took all of those vision statements that we just went over and put them into this Wordle, which it makes, the words that are used the most the biggest. And so you'll really see that Oregon has defined its public health system for itself, and that's something that's a huge accomplishment for this state. Not a lot of other states have gone through the process to define what the foundational programs and what the foundational capabilities are for public health. And so yay, Oregon. I think that in and of itself is a huge accomplishment. So Sarah mentioned that our state and local modernization assessment is complete. April, completed on Friday. So I'm here to share some very high-level results with you. If this presentation was next month, I'd have a lot more to share with you. So I'm going to apologize up front. This is going to be pretty high level, but there are going to be plenty of opportunities to talk further about the results as we think about implementing this huge systems change. So about the assessment process, there were 3 phases, and this was done at the local level, and I'm going to really talk about what we did here at the State Health Department. And the first phase was really our programmatic assessment. So we took those definitions. If anyone's downloaded or looked at the manual, it's about this thick. I think it's 300 pages or something.
It's only 100.
It's only 100 pages. Okay, so it's 100 pages. And we looked internally at ourselves, line by line, of the whole manual and rated ourselves on capacity and expertise with cross-divisional groups, and there were over 125 public health division employees involved in this process and many, many more that were consulted, where we took a hard look at ourselves and we said, do we have the capacity to meet this definition, and do we have the expertise here at the health division? And then we rated ourselves on this scale, and We picked capacity and expertise because we realized that those are two very different things that help us understand how we're doing in meeting the definitions. And as a very high level result, we are for capacity kind of across the board in this 3 to 6 range, between sort of able to provide things at a basic level but almost to not currently providing. So that's sort of where we're at in capacity, the 3 to 6, 7 range. And then in expertise, we're actually a little bit higher. We do have a lot of experts, and we do have a lot of content expertise here in the division. Sometimes it's a very limited. We might not have enough of that expertise, but we're in that 6 to 8 range for expertise. So to just give you a little picture of sort of where we're at here in the division, we've got some expertise, not quite as a capacity, and we're actually have a lot to work to do around health equity, partnership work, and leadership and organizational competencies. So those are some of the areas where we were ranked a little bit lower. Is there a question? I heard a noise. No? Sabrina? Good. Let's see. So the second and third phase of the assessment, phase 2 is our current spending. So I think this gets at your question before. We worked very closely on this very tight timeline within the division to work with all of the programs across the whole public health division and put our current spending into the buckets. So all of the things that we just talked about, which is not something we've ever done before in the division. We have our federal programs, we have our grants, we have our dollars that we spend, and we had to figure out which dollars are spent on non-foundational public health, which dollars are spent on foundational public health, and then put them into buckets. And the high level result from that is, not surprisingly, most of our current spending is within those 4 foundational programs. So prevention and promotion, environmental health, access to clinical preventive services, and communicable disease. We spend very little money currently in the capabilities. So I don't think that's a surprise. That's why we're on this journey to begin with, but that is our high level result for current spending. And then we're just wrapping up this week our cost projections. So we worked, again, with some cross-divisional teams around, we have our programmatic assessment. We said we were a 4 in this area. What would it take to get us to a 10? And we had a lot of conversations about what that would be in terms of personnel, contracts, training, IT, human resources, and we came up with a number, and we're currently working on what that number is and what that number means, and that will be part of this big assessment report that we're pulling together. But in addition to the resources that are needed, it really started some great conversations around how we're structured around this work. So simply just adding more money on top of a system that might not work isn't necessarily the answer. So this has given us a real opportunity to also look at how we currently do our work structurally, and we'll be beginning those conversations as well on top of what resources do we need to implement a modern public health system. So really great momentum, a lot of great things that are happening right now. This is what I have to share with you for today. So are there any questions? Yeah, Steve.
This might be a silly question, but in the cost projections, was it always what do we have to spend to achieve 10? Or was it like maybe an 8's okay for this?
Yeah.
Was it always the perfect score?
Well, that's a great question. So we started out, I think, our journey on what could take us to go from a 5 to a 10, realizing that the number we needed to come up with was for a year, and that even with a huge influx of resources, 1 year is not going to get us from a 5 to a 10. So we started thinking about what's the long game in this. And so those long-term implementation plans are due in 2023 for state and local public health. And so I think we'll be taking that timeline. So we started out big picture, what's the huge light at the end of the tunnel, dialed it back a little bit, but we still have all that information to help us with the long plan. But we kind of came to that realization mid-assessment. So, any other questions? Yeah.
I kind of on that. Are we seeking a 10? Or are we seeking?
Yes.
Okay.
We're seeking a 10. We're seeking to fully meet the definitions. I think we have to figure out what the timeline is around going from a 5 to 10, particularly because we're so low in capacity in some areas. And again, just throwing money on top of a system that isn't quite aligned around these areas isn't going to get us to a 10 in a year. So what can we do to start planning long term around that? And that is to be determined. Yeah.
So although all of the focus here is about the foundational programs and the capabilities, what about the non-foundational things, the things that you're seeing that you're spending a lot of money on, even potentially more than currently on the foundational things, and those non-foundational programs and services and whatnot are still achieving some positive outcomes.
Mhm.
So there could be some kind of substitution effect even. It's like, well, maybe we don't have to spend up to a 10 on this foundational work because we've got some non-foundational work that's achieving the same outcomes. So how are you kind of factoring in all of this non-foundational work if you have the long-term vision on outcomes?
That's a great question. Most of the non-foundational work is related to direct service. And so I think it's identifying what is our role in that moving forward and what is our role in the foundational area. They do align very well together. So I don't know if I am answering, there's still very important services. We are looking at the foundational pieces and making a plan for that, but we're not going to stop doing that work right now. There's a lot of conversation that needs to happen around the direct service piece. Is that inaccurate?
No, I agree. It's part of that planning that you were talking about when we're maybe using less resources on direct services in some places. There's a question about how that additional resource could be used in lots.
So I guess, kind of the nugget that I'm hearing from that is that it's the non-foundational work is a lot of direct service.
Yeah.
So, because I was thinking there might be like, you might get a big chunky grant, for 10 years or 5 years or something that's going to do something that's not necessarily direct service, but it's like a good program, but it's not really foundational, and that's what I was wondering about.
Yeah, I think the conversation we've had around other important services or non-foundational has been very much around direct service. So, yeah. And just in general, there's a lot of resources we need around economics, health economics. So what are we getting? What's our return on investment in certain areas? Evaluation, informatics, having our data systems talk to each other. So those were some of the things that came out of the cost assessment piece. Yeah.
So apparently I'm not going to give up on my first question.
Oh,
So,
did I not answer it?
No, you did answer it, and then you also answered Holly's. But then kind of back to Holly's comment. So you said we're trying to achieve a 10 on everything. So
Yep.
the underlying assumption there is that all of these foundational capabilities and programs are created equal. Like we don't want to. Do you understand what
Yes.
my question is?
Yes.
Okay.
I would say they're all created equal, but there's an implementation plan that will be developed, and I think some conversations will have to happen around, do we start working on the areas where we're a 3 and bring those up first, or do we start working on the areas where we're an 8 and get those out of the, kind of a tailoring, a tiered piece? We have not had that conversation at all yet, but that's a good thought. I don't know, Sarah, if you have anything to add. No, but they're all all important. Yes, equal.
Sorry, I wasn't trying to get you to say that.
No, like.
Look, when I read the reports from the task force that was working at this, I remember the first task force, there was a lot of discussion about, do we go for that thing, or do we sort of step back a little bit and maybe shoot for an 8? And there was quite a bit of discussion about, like let's not shortchange ourselves. We're in this problem in part because we constantly shortchange and cut back, so let's not do that. Let's talk about what is, not the gold-plated system, but what is a 10? What do we really need to achieve that? So I would encourage us not to have a sense of like, we can do without.
Yeah, and the only thing I would add to that is we define these areas and the definitions are pretty tight. I think in Sarah's first slide, she put up the picture of what does governmental public health do, and governmental public health could do everything or anything. We could be huge in scope. So part of this process is what are the foundational things that we do, and then how do we get to achieve excellence in those areas and not get distracted by, I think, some of the other things that might pop up. I don't know. I remember when I was getting my MPH, someone wanted to do their internship at an architecture firm because they were linking it to public health, because it is, but we're not in the field of, architecture. So we can do anything and everything, but we want to really define ourselves and achieve excellence in those areas, if that's just to add on top of what Sabrina said. So I know we're Okay, I'll take one more question, then Sarah's got some more stuff to talk about.
Okay. Well, actually, I have kind of two parts.
Sure.
In the larger vision, I think health promotion, et cetera,
Mhm.
was called out. And I saw chronic disease there, but I didn't see maternal child health, early life, et cetera. And that troubles me because a good proportion of the population are in that category.
Yeah.
So is that embedded in there? And I see injuries, good.
Yep.
I missed that. That's one question. The other question is, I'll get back to what I was saying, most people don't understand public health.
Yeah.
So in these products so far, is there a plan or a direction for communication and dissemination?
Yes.
And what is that, and what are people thinking at this point?
Yes, well, I'll answer your first question, and then I think when Sarah gets into next steps, we'll talk about communication. But just real quick, this again is the vision for prevention and health promotion, where not only the chronic disease prevention work is, but maternal child health is in here, and we do talk about supporting health and development of Oregonians across the lifespan. So we got that in there. All right, turn it over to Sarah, because we do want to promote our room.
Oh, yeah.
Okay.
You're telling me to speed it up?
There you go.
Okay, so what's coming for the rest of 2016? So the FAB I mentioned earlier, our Public Health Advisory Board, is meeting monthly. And as I also mentioned, they have a very defined role now. So not only do they just broadly have oversight of the governmental public health system and specifically public health modernization, but they have these buckets of work to do. So a lot of their work will be developing a funding formula for public health modernization, which includes incentives. So should funding ever become available to support this work, that funding formula is in place. I've also mentioned a few times the importance of this being outcomes driven. And so the Public Health Advisory Board will be developing those health outcomes. And then what they develop, what they recommend, then goes up to our Oregon Health Policy Board. So they've got some big body of work to accomplish this year. I don't think we've mentioned yet that we're working with a contractor around this entire modernization assessment. So the contractor is Burke Consulting. They're out of Seattle, Washington, and they also work closely with Washington State, which is going through a similar process around foundational public health services. So Burke developed the assessment tool, they're doing all of the analysis, and they're writing the final report, which will be available in June of this year. So once that report is available, it will be submitted to Legislative Fiscal Office, along with some other information about the work we've accomplished in the past year. We're working with Program Design and Evaluation Services. They're doing some really amazing modeling work to show, like, if we're able to do this foundational capabilities and programs work, what are the health outcomes that we're going to achieve? So looking at diseases avoided, lives saved, savings to the healthcare system. So it's not again just about changing the system. It's really about improving health outcomes. Do you want to say anything more about that?
That covers it.
Great. Okay. And then, it is time to get out there and start doing this work. So late last year, Oregon was one of 3 states that was invited by the Robert Wood Johnson Foundation to apply for a grant. And the purpose of this grant is to take wherever we're at with modernization, foundational public health services, whatever you want to call it, and move us forward on the trajectory. So they're funding 3 states, Oregon, Washington, and Ohio, to do this work. In Oregon, it's actually our Conference of Local Health Officials that applied for and received that grant, but we'll be working very closely to move this work forward. And the bulk of the work is going to be around beginning to develop those local or regional plans to implement modernization. So convening stakeholders in the community, developing tools for how to do this work, creating a roadmap for how to do this work. really raising awareness about public health, about the importance of public health modernization, and gaining some momentum around those efforts. So that work will be happening beginning in about a month and continuing. The grant lasts for, I think it's a 20-month grant. And then the last thing on this slide, we need to submit a report to the legislature, our statewide modernization plan on January 1st, 2017. So this will be our plan for how we're going to do this work, defining our timelines, the waves of how counties might begin doing this work, include information about funding formulas for if and when funding is available for this work. So, still much to do. I've already talked about FAB. I just wanted to show you all who our current Public Health Advisory Board members are. You can see there's great representation by local public health. So again, this board is overseeing our entire public health system. Let's see. So what can we expect as we move toward a modernized public health system? Our system is going to be able to quickly respond, have sort of nimbleness in there to address whatever comes up, whatever emerging event comes up that needs to be addressed, because our system will be more flexible to be able to do that. It also allows for more flexibility, so again, not a one-size-fits-all approach in Oregon, but individual local health departments are going to be able to meet the needs of their own communities. There's going to be flexibility built into the system. The public health system, state and local public health departments are going to be the leaders. They're going to be the leaders in their communities for policy work. They're going to be a trusted source of information because they're going to have all of that knowledge, skills, and abilities through those foundational capabilities. Again, continue our work and grow our work to ensure that community members have access to healthy foods and safe places to be, enhance our data surveillance and use all of our data to drive decision making. And then again, I just wanted to highlight, we're moving toward a system that works more in alignment with health system transformation, with early learning, so that we can capitalize on the strengths of all of these systems throughout Oregon and support each other's work. That might be all I have. We can definitely take questions when you leave the room. We're really hoping that you will go one door over to 1C, because we have a modernization room of hopes and dreams where we're just trying to capture feedback from people about what excites them, how they see all of these different pieces connecting, what they need from the system, and we'd love to get your feedback too. So stop in for a couple minutes when you leave. But for now, let's take some questions.
The briefing that will happen, when was it, April? When did you say the next briefing?
The next internal, the public health. So within the public health division, we will be using those fourth Friday meetings to go take a deeper dive in the results of each of the capabilities and programs. So we'll be doing that soon. Is that what your question was about?
Yeah, I was trying to think what the next. And will local assessments be a part of that conversation, or is that happening separately?
Yeah, so the fourth Friday, we'll be able to talk more about the public health division assessment. As I mentioned, we're working with a contractor who's writing that report on the modernization assessment for the entire system, and I think when that report is available is when we'll have information more broadly about the public health system, including local public health.
So you mentioned the benefits of the kind of alignment with health system transformation and the CCOs and all that. So I guess first, is there a CCO representation on the Public Health Advisory Board?
Yep.
Okay. And then kind of like, are they doing something on their side to be aware of and contribute to, other than just that one person who's on the advisory board? So are they like all excited about the alignment with what's happening with public health modernization?
I don't know that, but I can tell you that, you know, as CCOs develop over the years, they are taking on so much of a larger role in you know, improving the health of communities. They're not focused exclusively on their own members anymore. So they're beginning to understand public health a little bit more or work in that arena, and this is an area where we can really support their work.
And I would just add that while it might seem like public health is sometimes separate within this larger, broader Oregon Health Authority agency, we are all under one umbrella, and our director, Lynn Saxon, is very supportive of public health modernization and bringing these things together. It's one of her top 10 priorities, and so I think just being within the same agency will provide a lot of opportunities for us to have that conversation. Yeah, so.
The next step is going back to the legislature. What do you think that that's going to look like? What kind of ask might it include?
Yeah, so I mean, what we'll be giving them in June is the assessment report, and the assessment report is going to have a dollar figure. This is what's needed for the public health system to close the gap between where we are now and where we need to be a modernized system. Also at that time we'll be putting forward sort of an update on all of the work, because I don't think we mentioned that House Bill 3100 did come with $500,000 for us to do planning and implementation work. So we need to tell them how we've been spending their investment and how we've used it. I can tell you that, you know, our leadership here within the division and OHA is you know, working on a strategy for moving forward, but I don't have information about exactly what that's going to look like.
And what part of the legislature is the report actually going to?
So the assessment report actually needs to go to the Legislative Fiscal Office. But we'll share it as well with the key legislators that have driven this work, largely Mitch Greenlick. I mean, it's great work. We want to share it as broadly as possible.
What about what's thinking around reflecting back to the local health departments, not just their own results, but sort of the lay of the land of the field?
Yeah, so, you know, a lot of that will probably happen through FAB. You know, there are 6 local public health representatives on the Public Health Advisory Board. There's also the Conference of Local Health Officials that will be communicating information back. And then a lot of it will happen through the funds provided and the outreach that's going to happen through that Robert Wood Johnson grant. That should kind of kick off within the next couple months. Okay, well, we sure appreciate your being here. Don't forget to stop next door. If you have any questions, we'll be here for a couple minutes. So thank you.
Thank you.